So my name is Agnes Ayton. I'm a consultant psychiatrist working in Oxford Health.
And I'm David Viljoen, so I'm a consultant psychologist. I used to work with Agnes, and I also now work in a private inpatient unit.
So we have been working together since 2016 or
15.
2015,
Yeah.
okay. Both of us have had a very strong commitment to improve treatment outcome for people with severe eating disorder. The majority of the patients who are admitted to inpatient units in the country suffer from potentially life-threatening anorexia, so they are really severely ill and the outcomes are poor. We were very interested to find out about more effective models than the treatment as usual in the UK.
Yeah, and I think it was ultimately about a model that will think about the whole pathway, so across inpatient, day patient, and outpatients, and also how we can work together as a multidisciplinary team, so to use the whole team effectively in a comprehensive, cohesive model rather than people working in silos or in separate disciplines, using different models rather than a single integrated model, and also to be more evidence-based, because there is a lot of services that perhaps don't use evidence-based treatments.
The first step in the journey was to visit the Garda unit in Italy. So we went in 2016 and I kind of examined the similarities and differences between the NHS and the Italian model.
And I think the challenge was to bring something back to a multidisciplinary team context and also the NHS context, where rather than perhaps Viljoen, which was a privately funded unit.
And I am very grateful for your help during that challenging time, because it required quite a lot of training. So we had to train the staff, and David helped to develop new programs so to make sure that every patient received personal formulation, that the team were aware of the individual formulation. And then we developed a group program which actually incorporated the CBT for eating disorder aspects to make it kind of completely comprehensive.
Yeah, and I think, first of all, the formulation I think was really important. So to think about all the possible maintaining factors for somebody with an eating disorder. So you have to think about things like body image, you have to think about all the kind of dietary rules that they may have in terms of dietary restriction, how they ultimately then lose weight, some of the compensatory behaviors that people may use. Also to think about things like their self-esteem, how they manage their emotions. Some people with eating disorder struggle with perfectionism, or they have interpersonal difficulties. It's about how all these things sit together. Perhaps some people may have co-occurring difficulties like OCD or depression or anxiety or trauma histories. Some people have autism. So there's a unique profile that you need to develop for each person, and every patient is completely unique in terms of what they need and in terms of the treatment that's offered both psychologically, nutritionally, and also from the medical or psychiatric point of view. And that means then that you offer both individual therapy, and the frequency may be more than once a week, perhaps, which was historically offered in services, but then also to think about the group program. So in the end, it was a 20-week program with up to 4 groups per week, so effectively 80 groups in addition to individual therapy and the whole input from the whole multidisciplinary team. So that includes your nurses, your psychiatrists, your dietitians, social workers at times, and then also your therapists and family therapy, which I think is also really important.
And it was a very kind of challenging time, I think it's fair to say, because the team were skeptical whether that model would apply to the patients in the NHS. So the assumption from the team was that the NHS patients were a lot more complex. And we had an opportunity to evaluate this through the provider collaborative. So we had actually the largest study looking at different treatment models and their outcome. And what we found that with that integrated model, we had 70% good outcome, even though that the patients were all really long-standing. That is really encouraging, that actually kind of introducing evidence-based treatment into inpatient services can make a huge difference in terms of patient experience, staff experience as well, and long-term outcomes. So it requires some investment, but ultimately on the long term it could be cost saving for the NHS.
One patient recovered after more than 40 admissions. So we had another patient who recovered after more than 30 years. And similarly, another patient who was in hospital for never out of hospital for more than 6 months in 18 years. And all were very different presentations, which highlighted that because of the formulation and the personalized approach, patients who historically perhaps were viewed as revolving door or impossible to treat actually recovered. I think it also just what was important for the whole treatment program was the fact that it was seamless across the day patients and community. So these patients then went on to have community treatment after the inpatient part of the recovery process.
So the model really advocates for a gradual transition. That is what the patients want, and obviously that is what actually works in practice, so that's really good.
And I think patients don't want to tell their stories again and again, so the handovers between and the transitions was really important, because you had a good formulation, a good understanding of the patient that sort of traveled with the patient across the whole pathway basically. So there were good handovers between therapists from every step of the way, so that patients don't have to start again with a new therapist, or ideally the therapist followed the person across the whole pathway.
Well, eating disorders have a huge amount of stigma attached to them. So quite often we hear that eating disorder is somehow a personal conscious choice. And that is quite clearly not the case. So eating is absolutely essential for life. And people with eating disorders are struggling with emotional difficulties, but they're also struggling with some of the metabolic pathways that regulate eating behaviors. And it's really important to understand that eating disorders are not choices.
I would say that eating disorders are treatable, and there should be hope. But sadly, too many patients are going without the necessary treatment. So we do need funding, we need better services, well-funded services with better resources. We did a study where most community teams in the country were only 15% resourced. That means they're 85% under-resourced. And that means that too many people are suffering unnecessary, and that has an impact on their education, their family lives, even the economy in the country. So with better investment, better services, far more people can be treated. We also know that we've had many avoidable deaths, and that should also not be happening. If I had all the money in the world, I would invest in trying to understand and treat patients with long-standing eating disorders better. Because I do think there is about 30% of patients who don't get better yet. So we need to understand and develop better treatments for those patients, and ultimately avoid suffering over a long period of time, and also those avoidable deaths.
I probably would want to have first implementing current evidence-based guidelines, and then monitor and see how well they are replicated in real-life practice. So whether the current evidence-based guidelines produce the same outcomes in real life. So that would be one thing. But then the other thing is to understand a pathomechanism, the causes of eating disorders better. Because eating disorder complex, they affect both the body and the mind. And we probably understand a little bit more about the mind and less about the physical aspects of eating disorders. So I would be really interested to see more research on that.